Welcome, everybody. Happy October 4th. My name is Yoshi Lang. I am the project executive on Medi-Cal Connect. I'm also a family physician. I was a PCP in Contra Costa County for about 7 years before coming to the state. So that's my super quick background, and very happy to be with you today and sharing updates about Medi-Cal Connect, formerly known as the Population Health Management Service. Laura, you want to give your quick intro? My colleague, Dr. Laura Miller.
Sure. Thank you, Yoshi. Yes, I'm Laura Miller. I'm a primary care internal medicine physician, based most of my career in Alameda County, both with Lifelong Medical and with an MSO Community Health Center network. My role here on the project is as the lead for user and stakeholder engagement. So this is a key feature of user and stakeholder engagement, letting you all know where we are with the project and also really working to understand your challenges and work to solve them together. So we're super happy to be able to present this today. It's our second webinar on the status of the service.
That's right. All right. Vincent, next slide, please. So here is what we're thinking in terms of objectives today. We want to make sure you all understand our goals of Medi-Cal Connect, the functionality of it, our current state, where we're at on the project today, and then next steps for engagement. And then you can give us your questions in the chat, give us real-time feedback, and then we'll hopefully have ample time for questions in the second half. All right, and then next slide is our agenda. We'll cover vision, goals, objectives. We'll give you the status update. We'll also show you screenshots of our dashboards that DHCS users have begun to use internally. And then we have just a couple of polling questions that we want to get your input on. And that's it. Yeah, we'll get your feedback. All right. So on the next slide, we'll pause here for just a second because I like to give the explanation of Medi-Cal Connect in my own words. So when family and friends ask, "Hey, Yoshi, what are you doing at work these days?" This is how I say it. And it's a really complex project. So this is why I like to say it this way. We are gathering data from our various trusted partners across the state and bringing it all together, aggregating it, and then making it available to those partners, including members directly, all for the purpose of closing gaps in services and improving health. So that's it in a sentence. And also, I'll pause here to say that no other state in the country has done something like this. So it is really groundbreaking, game-changing, whatever catchphrase you want to use. But no one's pulled data together like this for all Medi-Cal members across the state to do what we're doing. So it's very exciting, and California is we should feel proud of all the things we're doing in California, leading the way. All right, next slide. A little more formal vision of Medi-Cal Connect is here, which is that it's a data-driven business solution supporting whole person care by integrating information from trusted partners to support population health functions and allow for multi-party data access and sharing. So that's our more formal version of it. And yeah, I'll just leave it at that. I think in the next slide, then we'll go into our 4 major goals of the service. So this is how we're going to enhance our ability to deliver the best Medicaid program in the country is with these goals of Medi-Cal Connect. I'll start with member experience on the left. So our concept is that we would have a member app or portal, and this would be something where a member it would streamline their access to services, it would help them navigate benefits, and then reduce gaps in services, and also allow self-service updates like updating their contact and demographic information. And I like to use the example of WIC and take it through these 4 buckets of goals. And in this example, this would be like a member looking at the app and seeing, okay, I have Medi-Cal, I have dental benefits, I have vision benefits, and here's this thing called WIC, and I'm likely eligible, and here's the link where I can go sign up. And then we close that gap in service, right? And we know only half of folks eligible for WIC in the state are enrolled in WIC, and yet we know that WIC is correlated with lowering rates of premature birth and low birth weight. So, right, if we can make a bump in something like WIC, that would make a real impact to health across the state. Second big bucket of goals is whole person care. So this is things like being able to view members' risks and unmet needs. For example, seeing screenings and assessments that are required by DHCS, that would be in Medi-Cal Connect and be shared between plan, for example, and CBO ECM manager. And then we will have, for the first time, a statewide risk stratification algorithm. This will be the only portion of Medi-Cal Connect that the plans are required to use. So we can talk a little more about that, but I think the risk stratification algorithm could be a whole other talk in and of itself. The third big bucket here of goals is population level insights, of course. So we're going to aggregate all this data, and with that, we're going to be able to see population level health trends. We're going to be able to see where are the most glaring disparities across the state, where are the bright spots where we want to understand what is this plan doing in this county that's working really well, and what's a best practice we can spread. And then finally, informed policy making. So of course, this helps the department oversee and monitor how we're delivering on the Medi-Cal program and how we're doing in terms of impacting members' health. So there is so much potential here. All right, let's go on to the next slide, Vincent. And here, this is just putting Medi-Cal Connect in the context of PHM program. It used to be called PHM service, right? Because it is part of our same division within the department, PHM. And so we have PHM program side and we have PHM service side, which is now known as Medi-Cal Connect. And I think probably everyone here is familiar with the PHM program, which of course is, it's said right here, but this is how we are developing and delivering a whole system person-centered strategy. And the scope there, again, as I think most of you know, that is, the scope is MCPs, right? The PHM program is all about what we're asking MCPs to do in terms of population health. And that launched in January last year. Medi-Cal Connect, however, is not only the backbone of the technology and data backbone of PHM program, but if you look at the scope here, it goes beyond the MCPs. So the infrastructure includes, right, county behavioral health. It includes our ECM providers, CBOs out in the community, state partners and agencies. You'll see the whole list of users as we go on in the presentation, but the users of Medi-Cal Connect is a much longer list, including members themselves. So the initial release has already gone live for DHCS, and then additional components are going to be available over the next, say, 15 to 18 months. Okay. Next slide. This is a visual to represent how we're thinking about prioritizing users. And so you can see at the center Medi-Cal members, because it's all about trying to improve the health of our members to make sure that they can navigate the services that they're eligible for, but are probably not using all of them. And so I won't rehash the specific points here, but this is more to illustrate, right? Everything we're doing is to improve their health. And then surrounding them are all of you, the Medi-Cal plans. And so with Medi-Cal Connect, we're providing functionality not just to members, but of course to plans as well, so that you all have the data that you need to help deliver on the population health management program. And then for DHCS, we will also have that data so that we can help support plans and members to improve member health. So that's why I like to show this. And it's going to be, I think, a really powerful tool for DHCS to partner with plans to improve delivery of population health. Okay. So next, status update and our release timeline is next. So who's getting what and when? So this slide, we show who the users are and what functionality they're going to get in which release. So release 1 already happened, like I said, this past July, and these are our DHCS power users. So it's a smaller group within DHCS, and of course they got the fundamental requirement of Medi-Cal Connect, which is that it supports analytic capabilities, and we have 3 dashboards so far, and you're going to see screenshots with synthetic data. You're going to see the 3 quality measures, condition prevalence, and health equity dashboards. Then release 2, that is when we plan to go live for all DHCS users. And the original dashboards in R1, those are going to be improved and enhanced. And then we're going to have some additional dashboards, which will get at trying to look at program performance of things like enhanced care management, for example. And then in release 3, that's coming 3rd quarter of, oh, it says Q3. I think it should say Q2. So sorry, just caught that. The plan is for Q2 2025. And this is for all of you, the MCPs, county behavioral health, state partners, and agencies. And there's going to be 2 ways that R3 users can interact with the data. So via API or a portal with dashboards. And so that's one of our polling questions today is about APIs. Actually, both of them are related to APIs. Then the other functionalities that you all will get is the ability to collect and share the screenings and assessments that I mentioned, care plan information, member contact and demographic information, and it's not just a care plan, but really care team contact information. We really want to be able to share if this member has a care manager, what's their name and phone number, how do you get a hold of them? And then the risk stratification, segmentation, and tiering algorithm. All right. Next slide, going on to release 4, which is Q3 2025 for our other delivery partners, which is essentially the same functionalities that you'll all get in R3. In R4, they're going to go out to our local county partners, service providers, healthcare delivery partners, and tribal partners. And then last but not least, R5 in early 2026 is for members. And we made a very intentional decision here to go live with members last, because we know we're only going to have one shot at this to get it right for members to actually pick it up and use it. And so we've done a lot of engagement with them already to inform what exactly we will deliver for members. So we've talked about those functionalities already, and then we'll continue to evolve the R1 through R4 capabilities. And then finally, after we finish all those initial releases, we plan to have quarter releases. So that's going to be for maintenance, continued enhancements, continuing to add more data sets. We have a long wish list of data sets that we're getting. And I realized I didn't talk about the various data sets we're intending to gather, but right now we have our claims data, of course, which is internal to DHCS. We are getting very close to having WIC and CalFresh data. And then eventually we will have corrections data, housing data, and the list goes on. So now on the next slide, I'm going to turn it over to Laura to talk about where we are with engagement.
Great, Yoshi. Thank you so much. Yeah, we're diving into my world of user and stakeholder engagement. So we've had multiple touch points along the way and are continuing those multiple different ways of learning from you all and really folding your feedback into the service. So there are webinars like this one. This is our second. We've split them into webinars for plans like this and webinars for other early adopters, including state partners and agencies, health delivery partners. And you'll get a flavor. I mean, this is our webinar format, but we use it both to communicate out and solicit feedback and gain additional insight. We've also had many, many discovery sessions, and these are individual sessions with plan partners to really have a conversation about validating assumptions, identifying gaps, exploring additional opportunities. And I'll in the next couple of slides, I'll say a little bit more about what we've learned to date. We also did a survey that went out to chief medical officers and county directors to assess current capabilities and needs. And just a little bit of a sidebar on that one. This release 3, is both medical, physical health plans and behavioral health plans. So we've combined the two in release 3 in this stakeholder group, but also are really cognizant of differences and needing to understand those differences. We've also engaged in small group discussions, one-on-one sessions with plans focused on our particular value propositions of the service. Next slide. This is really a summary of what we've heard in the surveys and the discovery sessions and all of our conversations. And none of this should come as a great surprise, really. Plans want access to complete and accurate data, also from new sources. Physical health plans don't need claims data so much. They own claims data, right? And they work with that. But I think the real value for plans is, especially physical health plans, is all of the other data that we are bringing in. Plans want improved data sharing mechanisms back and forth. There are, of course, the MOUs, but certainly the service can support data sharing. We heard loud and clear the desperate desire for accurate member contact and demographic information. It's in every sector of our healthcare system. You can't take care of somebody if you can't call them. So we're actively working on that challenge. I think one of the benefits of the portal, member-facing portal, is that folks will be able to update their own contact information should they so desire. And then also, it will give access to standardized screenings and assessments data. One of the things that we heard early on, and this was in fact back in the days of J.C. Cooper, our former state Medicaid director, patients don't want to fill out screening after screening with the same information. It's re-traumatizing. So if we can find a way to standardize and build essentially a central repository for those screenings, that will be a good step forward. Overall, our goals that we've heard from you, is facilitating data aggregation and delivery. We heard loud and clear, dashboards are nice, but the plans want APIs, and we get that, and we're actively working on that. We also heard clearly that folks want streamlined methods to understand and act on population health level trends and be able to really operationalize the PHM policy. So all of those pieces are really what we've heard to date and how we're weaving it into the service. Next slide. So, looking ahead, we are going to have small group discussions with plans to talk about these really sort of hot issues where we want to hear from you and understand the challenges and be able to build solutions into the service. So, data completeness and integrity, super important. We hear from plans that there are challenges with data that's received. We want to really understand those and work to improve. I've mentioned more than once the accurate member contact and demographic information and consent management. Of course, folks are concerned about consent management. And even though member contact and demographic information may seem simple on its surface, it's actually complicated in terms of who gets to update information, where is that stored, how is it validated. So there are a lot of pieces we need to work out there. We'll also be having small group discussions on care plan and screening and assessments, just to understand what are your needs and what are the possibilities there. We'll also have sessions on RSST, the risk stratification and tiering that Yoshi mentioned, as well as program eligibility identification. DHCS knows that we can flag eligibility as a point of inquiry, but we don't determine full-on eligibility. So it's a complicated issue, and we'll need your help to work that out. We will continue to have webinars and other engagements activities like the discovery sessions, working sessions, and like this webinar, we'll have continued sharing out. Next slide. So this is a little bit, you saw the releases, the 5 releases of the service. This is a similar timeline, but coning in on user and stakeholder engagement. So we are right here with our green arrow at webinar 2 for both plans and other early adopters. We will definitely have other touch points with certain individual stakeholders as we go along. When we are reaching out, we will absolutely give 30 days advance notice for meetings. And we do want to focus our engagement on feedback, status updates, configuration, and identifying distinct needs. So it's definitely multiple ways of communicating and hearing your feedback and incorporating it. And this, again, this is the timeline of the releases, but you can see that at Q1 25, we'll have webinar number 3, etc. And it's actually, Q2 25 is release 3 that will be plans. So you'll be hearing a lot in that Q1 webinar of 2025. Next slide. So I'm going to take you through I have to call it a semi-demo. We will not have a live demo, in part because of issues of suppression and PHI, but we will give you screenshots so that you get the look and feel of what we've developed so far. And again, this is 3 dashboards for DHCS super users. I saw the question in the chat. It's a small group of DHCS folks. Again, we're taking that iterative approach, and a small group of users have access to release 1. What you'll see contains no PHI. It is synthetic data. So please don't draw public health conclusions from what you see on the screen. And these dashboards show the view that we see at DHCS. Plans will have a somewhat different view, but we wanted to provide transparency into what DHCS is seeing. So let's go on to the first dashboard, which is the quality measures dashboard. It's the first of 3. One is quality measures, one is condition prevalence, and the third is health equity. So for this quality measures dashboard, and I apologize for tininess, but you can see that we have measurement year You can pick a year. This is coned for 2023. And then pick an initiative. This is looking at the CMS core set on children's preventive health. And then when you click those two drop downs, you will see all of the quality measures that roll up into the CMS core set, and you'll get a sense of performance. And again, the target MPL at 50, this is synthetic data, but we are able to really look at performance across the state. It's a little hard to see, but in this, we can also look at quality measures by demographics and quality measures by plan. Again, this is the DHCS view. You can also see we have a map here that essentially will act like a heat map for performance, going from 0% performance up to 100. The particular example here didn't show a lot of variation. In part, it is because of synthetic data, but it gives you a sense of the capabilities that we are trying to build into the dashboards. Next, let's go to condition prevalence. In the condition prevalence dashboard, you can look at different conditions. I do want to say that the names of the conditions flow from the chronic illness and disability payment system, and they leverage the first and second diagnoses on a claim. So this particular example is looking at diabetes type 2 low, low meaning of less severity. It's also focused, you can see in the yellow up in the top banner, on Black or African American Medi-Cal members. And then one is able to look at utilization. So you can see the prevalence, but also you get a look into the utilization of folks with of that demographic and with that disease state. Again, this is synthetic data, but we wanted to give you a flavor for what we are looking at. The next slide is our health equity dashboard. What we see here is, again, you can filter by year. You can look at quality measures. I'm looking down the left side here. This particular domain is set for transitional care services, and the measure itself is plan all-cause readmission, one of our favorite HEDIS metrics. And specifically, what this is doing is showing, you can see that horizontal dotted orange line, that is population average, and then splitting out by age group. Even though it's synthetic data, there's nothing surprising here. We know that our elders tend to be readmitted more often. But it's so you can look at the age group and the population average for total plan all-cause readmission. You can look at sex, you can look at race, you can look at ethnicity. So this is, I think, really important to be able to break out and look at different demographic folks and see them in comparison to the state average. One of the things we think of when we talk about this is really this is to prompt questions. Dive in deeper, really try to understand what may be driving these issues and then work towards solutions. And I think with that, I am turning it back to Yoshi. Next slide, please.
Oh, I wanted to go back to the run chart on the first screenshot, Vincent, because when we did a webinar with the non-plans yesterday, the first screenshot, Vincent, that has the map and the line. Yes. So one of the key enhancements that's being worked on now is that it won't just be year by year. This will eventually be month by month. So you'll see a rolling month by month run chart there instead. And another question that came up yesterday, so I'm going to preempt the question now, which is what about the data lag? So this is based on our claims data, which runs a couple months um, behind. So this would be a few months of data lag from for what you would see in the dashboards here. All right.
I have a question. Are we allowed to pause for questions?
Yeah. Let me put up the first poll question, and then as people are responding to the poll question, we can chat. All right. So here's our first poll question. Do you currently use APIs to either send or receive data to other entities? And then you got a couple choices here. The first is yes to send information, or yes to receive information, or yes, we do both. D is no. And I realized we didn't have an option for not sure. That's okay. I don't expect everyone to know. So if you're not sure, I don't know. What should we do, guys? You could just say, maybe refrain from answering.
Probably.
Okay. Let's see. Oh, yes. And Laura, that's a good point about not for real-time decision making. Yes, this won't be Medi-Cal Connect, at least in the initial releases, not anytime in the near future. It will not connect to EHRs, so it is not a tool for making real-time decisions for patients. And Laura and I, as former PCPs, we know this is not a tool for a PCP. They would not be logging into this. This is more, maybe this would be a tool for a panel manager in the back office, but yes, not
Yeah,
for real
I
time.
had a question.
Yes.
So, I like the demo that you just showed or like the screenshots. I personally just don't think these are very helpful. I assume most plans have like analytics platforms like this where they're like feeding in
Right.
more data than you have access to. So, I mean, fine, like for DHCS to look at it, but I honestly don't feel like this is a very useful view. I think the contact information is one thing that is very useful of updating contact information. And if this is going to be a way for plans to identify when patients move, I think this is excellent. I think the big challenge now is like how do county transfers happen? And I think that's one of the big challenges. A member will say, we moved. You can update your database, but all you can tell them is to go to their human services department and contact the entering county. And I just think that's like a full workflow map that I'm sure that your team has done of like what is the current process for address updates and then what happens with county transfers of like which county is responsible and then which health plan is responsible. But I think that's a very complex workflow. And if this project just handled that, I think it would be extraordinarily valuable. Which I think is much more useful than the stratifying incomplete HEDIS data for plans, which they already do. Thanks. Just want to give that feedback.
Completely hear you. We've been talking about inter-county transfers. Know that it's a challenge. Certainly, the service would be able to show the new plan, information on the member, claims history, etc. The other piece, Beth, that I think is important to think about here is that we absolutely heard the piece around APIs, so integrating data, and the additional data sources that we'll be able to bring in. I think that's probably the key piece. We heard super clearly that we got dashboards, but access to the additional data, we definitely heard as an important thing.
Thanks, Elizabeth. All right, so yes to both receive and send. We got 50% and 50% no. Huh, interesting. And if folks aren't ready, or sorry. Actually, let me save my question for after we do the second polling question. But I think what I was getting at is, and Elizabeth, remind me, what plan are you at?
I'm at Contra Costa.
Oh, hey, that's right.
Hi.
I knew that. Sorry. Um, so for Contra Costa, the dashboards would not be helpful. But for the folks who are saying you're not using APIs currently, I'm wondering if the dashboards would be useful. And where I'm also thinking is, okay, so we would just concentrate more effort for the plans who say, hey, dashboards would be helpful for us. Then we concentrate our user stakeholder engagement around dashboards with those plans. So that's just where I was thinking. Let's go on to the next polling question. So if DHCS were to provide an API, how ready are you to integrate the data into your system in terms of, do you have the people, the resources to do it? Are the workflows in place? So what would you say on a scale of 0 to 10? Are you high, very ready, medium, moderate ready, or not ready? And this will also give us a sense of where we need to concentrate our efforts. So go ahead and respond there. And then let's see. I think Erica had another question. Yes, so plans will have access to their own data in these views. Yeah, and this is an active question, Erica, about would they be able to view data from other MCPs? So we are figuring that out. My hope is that at a minimum, MCPs would be able to see the aggregate data across the state and their region or county, so they can an MCP can compare how are we doing against other plans in our county, in our region, or compared to the rest of the state. So we are figuring that one out. I guess another question for you all is that helpful? I shouldn't presume that that would actually be something that plans really want to do. Erica, I'm going to put you on the spot. Would that be helpful? I think we can hear you.
Can you hear me?
Yes.
Sorry, triple muted or something. Yeah, Yoshi, I can't speak to whether it would be helpful or not. I think I'm just trying to wrap my brain around what the use cases would be. Like, what is the intended vision of what this is going to look like? I would need to take it back to folks internally to see how useful or not it would be, but I wanted to get a sense of what DHCS's vision with it.
I'm trying to figure out how to answer that other than repeat stuff we've already said. And Laura just said it again, which is those pieces of data. I realize that one polling question we didn't add here is what pieces of data, other than we know contact and demographic information is high priority, but I listed some of them. I'm curious if any of those are particularly enticing to you all. So I mentioned WIC, CalFresh, housing data, JI corrections data. I can pull up our wish list. But if anyone's saying, oh, that would be really helpful, I would just be interested in hearing from you all.
Yoshi, maybe we can
IHSS.
Yoshi, maybe we can finish this question and then do some polling in the chat simply around other sources of data. But I do think in response to your question, Erica, it really is about the whole person view and data that plans don't have at present. And really making that available, allowing you to integrate that into your systems such that you have a more robust view. we heard API super duper clear. Like DHCS, pretty dashboards, we have them. But what we really need is data and more of it and from disparate sources, different sources.
All right, so responses moderate to low. Okay. So again, this makes me wonder for the folks who are saying low readiness, not currently using APIs, would the dashboards be helpful? Can anyone in that camp speak to that? I would love to hear from you. Don't be shy. We don't know anyone at DHCS who would say, "Oh, that's not good that you don't have that." We're not those people. We don't even know who. No, I'm kidding. But half joking. We we won't share this. I'm trying to think if you don't feel safe to share. Oh,
I didn't answer this question as I'm not exactly sure where we are on our APIs, but I think that like the vast majority of data we receive from DHCS is through SFTP, through the plan data feeds, and through these like CDPH files. So I think like whatever way in which you're sharing patient level information, like I'd say like maybe offering both as options for people that are further along so they can at least get like through the connections. It should be part of a general data sharing. Shouldn't be like PHM service is doing one thing and plan data feeds doing another thing. Like obviously this should be like one data sharing strategy for DHCS and like in traditional ways that are happening in a transition to like the new ways that the state's kind of moving plans with APIs.
Yep.
You just don't want it to be separate on its own.
Yeah, 100%, Elizabeth. We actually have we call it a change request internal to the project to figure out how we coordinate around data sharing, like a data sharing strategy, as you're saying. So that's another thing that we are actively working on. And if you're not, oh.
Go ahead, Yoshi.
I was just going to say, if you're for folks who are saying not currently using API, don't feel very ready to use an API, but don't feel safe talking about it here. You know what you could do is email our Gainwell colleagues, and then DHCS folks would never even see that. I think if Sam, if you're okay with that, or Ingrid, you could put your emails in the chat. We did something similar with our discovery sessions where Gainwell team had conversations with plans, and like Laura and I would say hi and we left so that the plans could really speak freely about challenges involving DHCS. So we are doing our best to be good partners. There we go, Ingrid and Sam. So if you fall into the category of not using API, not feeling really ready to use an API, I think the question is, so would dashboards be more helpful for you? And we're happy to kind of lean in on engagement to make sure you have dashboards that are useful for you. Okay. I want to open it up. We officially have another 4 minutes for additional questions, concerns.
Let's go to the last slide or bring the slides down. It's just questions and comments. Yeah.
Oh, yeah. Feel free to turn on cameras, turn on microphones. Like I was asking before, if there are particular pieces of data, either data sets or specific data elements that you're interested in, would love to hear from you. Elizabeth, you got more?
I did have more. I'm sorry, I keep talking. So other item like that was on the earlier slides was about like high priority was sharing of assessment data between DHCS and the plan. And This just seems extraordinarily overwhelming to me because there are no standard assessment questions between plans, apart from a handful of like LTSS questions. So I guess like everybody has their own HIPMET, the people have their own HRA questions. There aren't necessarily data standards in terms of exactly what people are asking. And I don't know if that's been talked through, but this just seems like it could be a hodgepodge of like gobbledygook and nobody will, it's like a lot of exchange of data, but then nobody's going to know what to do with it because it won't flow into their own fields because it's like a differently worded question and different information. And I don't know. I would just like I 100% agree with JC Cooper on like people don't want to keep getting asked the same questions again and again. But I also think that that's occurring largely in the like transfer from provider's office to provider's office, not necessarily from like plan to plan, because most people don't change plans that often. So I just like I'm not really convinced on the efficacy of achieving that goal through like state or like plan to state data sharing like that like exchange unless the providers are like integrated on that and we have like data exchanges between Epic and Cerner on some of these standard questions because I just don't think like doctors' offices are still going to ask the questions again because I think it's like clinical duty. Like, why should you have to, like, what if something changed? Like, why should you, I don't know. There's certain things I feel like are always going to be asked again. And it's like a concern if they don't re-ask it. So I would just like kind of question that as a priority because I honestly think the utility of it may be a little bit less than some of the other things that are part of this like um, suite of services, if that makes sense. And that's going to be like so complex, and I don't feel like the value may be there on it due to some of those complexities. Thanks.
Mm-hmm. No, it's
Yeah.
really good feedback. I appreciate that a lot. I think one of the other groups that we envision using this is panel managers within clinics. Release 4 is for health delivery partners. And I agree, yes, some screening needs to be done, frequently. But at least it would going in and looking would give you a sense of what had gone on in the past. But definitely that's why we have these feedback sessions is to hear from you about what you're thinking about. So thank you. You mentioned briefly Epic and Cerner. It is not envisioned in near or even medium future any linkage with EHRs. Like that would be a wave the magic wand dream state. So that's really not on the horizon.
Maybe way far out on the horizon. We didn't bring up data exchange framework or QHIOs, but one of my personal hopes would be that in the future, Medi-Cal Connect would be able to link up with QHIOs and then ultimately be able to link up with EHRs. So not in the near future, though. Any other questions, comments? We'd love to hear what's on your minds. We can't see your faces, so we don't know if you're looking pensive or frustrated, hopeful.
I did toss into the chat an invitation to let us know about other data sets you might want to see. I believe we're in the process of getting HIMS data, which to me as a clinician would be a massive breakthrough I have yet to see in my life. So that's pretty amazing.
I'll bite. This is Sydney from HealthNet. I think, let's put ourselves in the hopeful and optimistic category. I mean, I recognize this is a lot of work that the smaller group has been doing to inform, and personally, somebody who's been eager to learn more. Maybe not the expert, but the screenshots of what you're potentially providing was really helpful. I don't think I had like, oh, it's going to be a dashboard kind of a look, right? But visuals are always helpful to kind of bring bring your vision together, and so that we can be supportive on this end as well. So put me in the optimistic category, but very eager to learn more. And visuals are incredibly helpful. This is a nice set of information for something that hasn't been more broadly discussed in like larger stakeholder meetings. So thank you, Dr. Miller and Dr. Lane.
Thank you. And slides will be available. There is a one-pager that we wrote on the PHM service. If somebody could toss that in the chat, that would be great. The slides will be available. This will be available as a recording as well. So, but thank you, Sydney. I know it's a huge, audacious project. And really, it's when I think about it, I think about partnership, about conversations back and forth. What do you need? What do you want? What idea doesn't seem like it's, the juice is not worth the squeeze to you? So really appreciate both optimism and curiosity.
Yeah, thank you, Dr. Miller. And I think if you're hoping for more feedback on the polls that you deployed, I know I personally could not answer them, but if you run it through the associations, you better believe we'll respond.
That's a really nice point. That's a really nice point. We can take that back. We don't want to induce survey fatigue. That's the thing. We really don't want to beat up on people with surveys, so we're using that sparingly. But maybe it would be worth another round.
Yeah, I would. I mean, don't worry about survey fatigue. There's it's not just your shop. It's okay. We can handle it. We want to inform and be at the table and participating in the conversation. If surveys is the way to do it and start understanding where we're going next. I'm speaking for HealthNet, not all of my plan partners.
Yeah.
But yeah. We want to learn more and learn with you and inform as we go. So thank you.
Great. And Beth, thank you about CIO groups, and Charlotte, thank you on CIHP. That's great.
Beth, is there a specific CIO group you're referring to?
I know LHPC hosts a CIO group, and so I think this may be, like, if you're looking for technical feedback, I don't know if any CIOs are on this call, but that may be a good group to kind of have a conversation with. But I know they have regular meetings.
Great. Thank you.
Polling questions in advance next time. That's a great idea. Thanks, Janelle. All right. Any final comments, questions? We want to make sure people have passing time. All right. Okay. Thank you all so much. I'm glad we had a little more dialogue at the end there. We look forward to more engagement, and we're working together to try to make this as helpful as possible to all of you and our members across the state. Thanks so much.
All right. Thank you. Stay cool.